Picture this. A 68-year-old farmer comes in 6 weeks after a total knee replacement. He is on rivaroxaban because that is what the orthopod sent him home on. He has got a bruise the size of a cricket ball on his thigh. He asks you, do I really need this expensive blood thinner? 4 years, the honest answer was, well, probably yes. As of this week, the answer just got a lot simpler. Good morning. It is Thursday, the 30th of July. 5 stories today. Aspirin dethrones rivaroxaban after joint replacement. An old antibiotic takes on carbapenem-resistant bacteremia. The IVF add-on industry gets a reality check. An intravenous iron in pregnancy shows a surprising benefit. Let us get into it. Story 1. Aspirin alone after hip and knee replacement. This is EPCAT 3, published in the New England Journal of Medicine on July 12, and presented at the ISTH Congress in Paris. Canadian led by Sudeep Shivakumar and the CanVector Network. 5,429 patients, double-blind, randomized, non-inferiority design. The question was beautifully simple. After a total hip or knee replacement, do you actually need rivaroxaban for those first 5 days, or is aspirin enough on its own? One group got aspirin alone, 81 milligrams, from day 1. The other got rivaroxaban, 10 milligrams, for 5 days, then switched to aspirin. Everyone continued aspirin for the standard duration, 2 weeks for knees, 5 weeks for hips. Follow-up was 90 days. The result? Clots, meaning proximal deep vein thrombosis or pulmonary embolism, happened in 13 of 2,700 patients in the aspirin-only group. That is 0.48%. In the rivaroxaban then aspirin group, 12 of 2,600. 0.45%. Nearly identical. The non-inferiority margin was set at 0.7 percentage points, and aspirin cleared it comfortably. The p-value for non-inferiority was less than 0.001. And here is the kicker on bleeding. Aspirin alone actually had slightly fewer bleeding events, 1.66% versus 2.04% with rivaroxaban. Not a statistically significant difference, but certainly not worse. No excess surgical site bleeding, no excess transfusions. Why does this matter for you? In rural practice, you see these patients in follow-up. Rivaroxaban for this indication is private prescription, around $40 a month out of pocket. Aspirin is $2 over the counter. The patient with the cricket ball bruise on his thigh. That is a real person. This trial says you can confidently use aspirin from day 1 after hip or knee arthroplasty in your standard risk patients. It simplifies discharge prescriptions, reduces cost, and does not compromise safety. Now, the caveat. This was a non-inferiority trial, designed to show aspirin is no worse, not that it is better. High-risk patients, those with prior VTE, known thrombophilia, or active cancer, were not well represented. You would still think carefully about those patients. The mean age was around 65, standard elective arthroplasty population. But for the vast majority walking through your door, aspirin alone is now defensible. This is the paper you forward to your orthopedic colleagues and your local hospital pharmacy committee. 3 EPCAT trials now, spanning over a decade, each one simplifying the message. The trajectory is clear. We started with low molecular weight heparin, moved to rivaroxaban, then rivaroxaban plus aspirin, and now aspirin alone. Each step removed a drug and kept the same outcomes. Aspirin is not just acceptable, it is the default. Story 2. An old antibiotic finds a new job. The Astarte trial, published in The Lancet on July 9. Spanish multicenter, 328 patients with bloodstream infections caused by cephalosporin-resistant enterobacterals. These are the E. coli and Klebsiella that laugh at ceftriaxone. You see them in your urine culture reports every week. Normally, for a bacteremia with one of these, you reach for a carbapenem, meropenem, or ertapenem. But carbapenem overuse breeds superbugs, and we are running out of options. Enter temacillin. It is a narrow-spectrum beta-lactam, naturally stable against extended-spectrum beta-lactamases and AMP-C enzymes, the very resistance mechanisms that wreck ceftriaxone. It has been around since the 1980s, but barely used. Astarte randomized patients to temacillin, 2 grams intravenously 3 times a day, versus meropenem or ertapenem. Clinical success at day 28, defined as cure plus no recurrence plus survival, was 74% with temacillin versus 73% with carbapenems. Non-inferior. The difference was 0.3 percentage points. Safety was comparable, though temacillin had numerically more adverse events overall, 60% versus 41%. Most were mild. 2 cases of C, difference with temacillin versus 1 with carbapenem. The Lancet commentary called this practice-changing evidence that alternatives to carbapenems exist for resistant bloodstream infections. Here is the catch for Australian practice. Temacillin is not currently registered by the TGA. It is only licensed in a handful of European countries. So you cannot prescribe it tomorrow. But this trial matters because it proves the concept, and it puts pressure on regulators and suppliers to expand access. When temacillin arrives, it changes your antibiotic stewardship conversations. You can treat the resistant E. coli bacteremia without burning through your last-line carbapenems. Keep this one on your radar. The O and G corner. This one is for talking to your wife about tonight. The IVF add-on industry just got a serious reality check. Published in The Lancet Obstetrics, Gynaecology and Women's Health in June, and led by Sarah Len Sen and colleagues at the University of Melbourne with NHMRC funding. This was a massive systematic review and meta-analysis, 85 randomized trials, evaluating 10 of the most commonly sold IVF add-ons. Things like pre-implantation genetic testing for aneuploidy, endometrial receptivity testing, embryo glue, endometrial scratching, acupuncture, corticosteroids, platelet-rich plasma injections into ovaries and uterus. Here is what they found. For 7 of the 10 add-ons, there was no evidence they improved live birth rates. None. And critically, the researchers excluded 72 studies for trustworthiness concerns, things like missing prospective trial registration or data integrity red flags. That is almost as many as they included. The reproductive medicine literature is polluted with unreliable studies, and clinics have been selling treatments based on that shaky foundation. Only endometrial scratching showed a possible benefit, roughly a 20% increase in the chance of live birth, but with moderate certainty evidence and a small absolute effect. Embryo glue and pyxosperm selection showed weak signals that did not survive rigorous random effects analysis. PGTA, the chromosomal screening test that many clinics charge thousands for, showed no significant effect on live birth in trustworthy trials. Corticosteroids, given to modulate the immune system around embryo transfer, showed no benefit at all. Why this matters? Australian patients are paying out of pocket for these add-ons, often without understanding the evidence. A typical IVF add-on costs anywhere from $300 to $3,000, on top of already expensive cycles. The Melbourne team built an evidence-based website to help patients understand what they are buying. The next time a patient asks whether they should pay extra for embryo glue or a receptivity test, the evidence says save your money. This is about patient advocacy and informed consent in your consulting room. Story 4. Intravenous iron for non-anemic iron deficiency in pregnancy. The FAIR trial, published in the Lancet Haematology. 600 pregnant women in Pakistan, all with normal hemoglobin at booking but a ferritin under 30. This is the woman who comes in for her first antenatal visit. Her blood count looks fine, but her iron stores are empty. Current guidelines say give her low-dose oral iron and move on. Half the women got a single 1-gram dose of intravenous iron in the second trimester, on top of routine oral iron. The other half got standard oral iron only. The result? By 36 weeks, the 4-iron group had hemoglobin nearly a full point higher, 11.6 versus 10.8 grams per deciliter. That is a meaningful difference. It translated into lower rates of maternal anemia at delivery, and, notably, reduced fetal growth restriction. No serious adverse events in either group. No anaphylaxis, no cardiovascular events. This was a single infusion, 1 visit, done. The practical takeaway. This trial argues for ferritin screening in early pregnancy, not just hemoglobin. If you find a woman with normal hemoglobin, but a ferritin under 30, a single iron infusion in the second trimester meaningfully improves her hemoglobin trajectory and may reduce fetal growth restriction. It also solves the compliance problem. Oral iron in pregnancy is notorious for constipation, nausea, and poor adherence. 1 infusion and you bypass all of that. In a rural practice with infusion capacity, this is a cheap, safe, and actionable intervention. The broader question is whether we should be checking ferritin routinely at booking. This trial says yes. Quick hits. First, the PDCAP trial, published in The Lancet on July 23. 1,100 children in sub-Saharan Africa with severe community-acquired pneumonia. Switching from intravenous to oral antibiotics once the child was clinically improving was just as safe and effective as the full 5 days of 4 treatment. Readmission or death rates were around 6% in all groups, whether they switched to oral amoxicillin clavulanate, or stayed on 4. Children who switched went home a full day earlier. And total antibiotic courses of 4 to 5 days worked, as well as 7 to 8 days. For rural pediatric practice, this supports early oral switch and shorter courses. Less cannula time, less hospital time, less resistance pressure, and less disruption for families. Second, PBS watch for August 1st. The main changes are brand deletions and supply substitutions. QVAR inhalers, both formulations, are being delisted. Several clopidogrel and insulin brands are being removed, including Humulin NPH and Humalog vials. Watch your prescribing software for brand substitution alerts from Saturday. Nothing major new listing on August 1st, but 17 drugs are in the pipeline for potential listing later this year, including Sofova for geographic atrophy, which would be a first treatment for that condition on the PBS. Ritalin LA capsules are also shifting brands, so check your scripts. Recap. Aspirin alone is non-inferior to rivaroxaban for clot prevention after hip and knee replacement. Simpler, cheaper, just as safe. Temacillin matches carbapinams for resistant gram-negative bacteremia, though it is not yet available in Australia. 7 of 10 IVF add-ons have no evidence of benefit, a Melbourne-led reality check. 4 iron for non-anemic iron deficiency in pregnancy improves hemoglobin and reduces fetal growth restriction. Argues for routine ferritin screening. And children with severe pneumonia can switch to oral antibiotics earlier than we thought, with shorter total courses. See you tomorrow morning. Stay sharp.